Diabetic retinopathy is a condition in which diabetes affects the small blood vessels of your retina. They are called the capillaries. Years of diabetes causes damage to these capillaries, causing spectrum of this condition called diabetic retinopathy. Unfortunately, diabetic retinopathy has no symptoms in the beginning. It's only in the later stages of the disease that the patient will develop symptoms. And because it has no symptoms, there is no way that you can know that diabetic retinopathy is happening in your retina unless your retina is examined by either a retina specialist or an ophthalmologist. Basically, you have to dilate the pupil and then examine the retina to find out the stage and the amount of diabetic retinopathy that you have. In the later stages of the disease, when the disease has advanced so much that there is blood inside your eyes, then you may suddenly lose your vision in one eye or in both eyes. You may develop a sudden onset of lot of black spots. These are the symptoms that you will develop when there is blood inside the eye in the later stages of diabetic retinopathy. In a condition called diabetic macular edema, where the macula of your eye gets swollen up with fluid, in that condition you will get a gradually progressing decrease of vision. That is the symptom of macular edema. So, like I said, in the initial stages of diabetic retinopathy, there will be no symptoms, and in the later stages, it can be either a gradual decrease in vision or it can be a sudden decrease in vision in your eyes. When diabetic retinopathy affects your retina, there is a lot of decrease in blood flow. This decrease in blood flow causes new blood vessels to grow in your eye. These new blood vessels are not as strong as your normal blood vessels. And what happens then is that from these new blood vessels, blood comes into your eye, into the vitreous, that is the jelly of the eye, and that causes sudden decrease in vision. So that is how diabetic patients end up with sudden decrease in vision. Once diabetic retinopathy has been clinically diagnosed, your doctor will decide what all tests to be done depending on the stage of the diabetic retinopathy. In the first few stages, you will not require any further tests except examination of the eyes, and you will be asked to control your hypertension and diabetes or any other comorbidities that you may have that can increase the diabetic retinopathy. In the later stages, we call it the severe and the very severe stage and the proliferative stage. In those stages, you will be asked to do usually two tests. One is the angiogram of the eye or the retina, and the other is a scan called the optical coherence tomography. Angiogram of the eye or a retinal angiogram is also called a fundus fluorescein angiogram. It is used to image the small blood vessels of the eye. When we examine the eye, we can only see the major blood vessels. So to image the smaller capillaries and to know how much blood flow is there in the retina and how much blood flow has stopped in the retina or how much ischemia is there, we use the fluorescein angiogram. In this, a small amount of sodium fluorescein dye is injected into the blood vessels of the hand, and then it reaches the retinal circulation, and photographs are taken by a specialized camera to capture the retinal blood vessels, especially the capillaries. This lets us know how much blood flow has decreased. It will also help us to find out the new blood vessels, the new, unusual and dangerous blood vessels that are growing in your retina in diabetic retinopathy. OCT is another imaging modality that we use in diabetic retinopathy, which is to find out how much edema is there in your macula. So macula is the central portion of your retina that is required for vision, and in diabetic retinopathy, edema fills up the macular area or the layers of the retina in the macular area, which is called macular edema. To quantify and qualify, to find out how much edema is there and what kind of edema it is, we use this instrument called the optical coherence tomography or OCT. Macular edema is when the central part of the retina that is required for vision, called the macula, has fluid inside or swelling inside, and that causes gradual decrease of vision. It is to evaluate this macular edema in detail that we use the optical coherence tomography usually. Once macular edema has been diagnosed and then quantified using the OCT, the treatment for macular edema is usually intravitreal injections, which means some medicine is injected into the central jelly of your eye called the vitreous. This helps the medicine reach the retina faster and also allows the medicine to remain in the eye for a longer time. The kind of medicine that is injected is usually what is called a monoclonal antibody against a particular molecule that is causing the edema called VEGF. So these are called anti-VEGF injections. There are various types of these injections, some of which are the original molecules and some of which are called biosimilars. These molecules that we inject into the eye, they remain inside for a limited period. The problem with macular edema in diabetic retinopathy is that the macular edema is caused by damage to these small blood vessels, which will remain for a long time and keep on producing these molecules that cause the edema. Because of that, you will not be able to get a response, sustained response with a single intravitreal injection. Most of the patients who have macular edema will require monthly intravitreal injections till the edema subsides and may require repeat injections when the edema comes back. So it has to be tailored according to the type of edema that the patient has and the response that we get to the various intravitreal injections. From a patient's perspective, the one thing that we have to remember is that once macular edema is there, you will require multiple intravitreal injections to control the edema. Another group of medicines that we can use for intravitreal injections is steroids. Steroids are also a good method of reducing the macular edema. Whether you require steroid for your macular edema or you require anti-VEGF for your macular edema will be decided by the doctor after seeing various characteristics of your eye and of the stage of the diabetic retinopathy. So bleeding into the eye or vitreous or pre-retinal hemorrhage is the cause for sudden vision loss. Now, how does this bleeding occur? It occurs from the small new blood vessels that have come that do not have the strength of normal blood vessels. These new blood vessels have come because of the ischemic state of your retina, and they then cause bleeding into the eye and cause sudden decrease in vision. Before the sudden decrease in vision occurs, if you can diagnose the presence of these new blood vessels by retinal examination and sometimes by fundus fluorescein angiogram, then you can get treatment to regress these vessels before they actually cause the bleeding into the eye. The treatment for these new blood vessels is usually what we call PRP, pan-retinal photocoagulation or retinal laser. Sometimes it may be augmented or helped by adding an intravitreal anti-VEGF injection as well. So the treatment is to regress these new blood vessels, and once they have lasered and regressed, after that you need regular follow-up to see that the new blood vessels are not coming back. If they do come back after 6 months or a year, they will require further treatment to get them to regress. Once you have come to the doctor with sudden decrease in vision and there is blood inside your eye, if it is a large amount of blood, then it has to be treated by surgery, what we call retinal surgery or vitrectomy. In that, you go inside the vitreous of the eye and remove the blood by a surgical procedure. Sometimes if the amount of bleeding is little or it has not affected your vision much, it may be helped by doing these intravitreal anti-VEGF injections and then laser to prevent the new blood vessels from growing again and causing further bleeding. But usually when there is a large amount of blood, you will require vitrectomy. Retinal surgery or vitrectomy for a diabetic retinopathy patient is required in the last stages of the disease. So it is when you have passed the proliferative stage and either you have bleeding into the eye, what is called vitreous hemorrhage, or your new blood vessels have now become fibrosed and they cause the retina to lift up. Then we call it traction retinal detachment. Or there is some adhesion of your vitreous to the retina causing elevation of the retina, what we call vitreomacular traction. These are the usual conditions in which you will require vitrectomy as the primary treatment for your diabetic retinopathy. Unfortunately, diabetic retinopathy to a large extent cannot be prevented because the major risk factor for diabetic retinopathy is the presence of diabetes, and it is the duration of diabetes that is the biggest risk factor for diabetic retinopathy to develop. So why are we treating diabetic retinopathy and why are we asking for screening? It is because blindness due to diabetic retinopathy can be prevented by early screening, early detection of the disease, and treating on time. You can prevent blindness due to diabetic retinopathy. The other risk factor is control of blood sugars. So the more controlled you are, the less likely that you will develop diabetic retinopathy, and the less controlled you are, the more likely that it will progress really fast. There are some other risk factors also, like presence of hypertension, which is increased blood pressure in your body, presence of anemia or decreased hemoglobin, presence of renal disease. So if you have a diabetic nephropathy, it can further worsen your diabetic retinopathy, and also some dyslipidemias, like if you have increased cholesterol and other lipids in your body. This can also cause increase in the diabetic macular edema. So the dictum is all diabetic patients should be screened by a dilated eye examination or a retinal examination once in every year. Beyond that, once you have a diagnosis of diabetic retinopathy, depending on the stage of your disease, you will be told to screen at various intervals. For mild and moderate, we will ask a 6-monthly screening. For severe, very severe, you may require further tests. But otherwise, bottom line is every diabetic patient, screen your eyes with a dilated eye examination every year. Pregnancy, though it is a physiological condition, can cause and worsen your diabetic retinopathy. But when you have gestational diabetes or diabetes that develop during your pregnancy, you don't have to worry about diabetic retinopathy. It will not happen. The problem comes when a diabetic patient, like you have a young diabetic patient who then becomes pregnant. These are the people who are at high risk of development and progression of diabetic retinopathy. So what is advised is that if you are a diabetic patient and you are planning to get pregnant, it is better to get a dilated examination before that, and once you get pregnant, every 3 months till the end of your pregnancy. And if you do have diabetic retinopathy, you will require more aggressive treatment than when we treat a non-pregnant diabetic retinopathy patient. Otherwise, it can progress throughout the pregnancy and then cause what we said earlier about the sudden vision loss.